Friends, welcome to my hospital at Ranaghat, India. This is a totally unedited phacoemulsification surgery. The main incision is being placed at a selected site. This is a 2.8 mm keratome and the incision is on the posterior aspect of the limbus. Viscoelastic substance is injected into the anterior chamber. This is 2% hydroxypropyl methyl cellulose. Now this is a side port on the right side of the main incision, and this is another side port on the left side of the main incision. Now capsulorhexis is to be done. I take a 26 gauge bent needle, introduce through the right side port and incise the capsule. A nice flap is raised. I take a a forceps now, hold this capsular tag, go anti-clockwise all around, remain at an equal distance all around from the margin of the pupil, and thus I get a round rhexis. And now hydrodissection. Must see that fluid wave goes from one side to the opposite side. Hydrodelineation is also done. The nucleus is tapped, and now try to rotate the nucleus, and I find that it is not rotating nicely. Do some more hydro there at around 8 o'clock. Try to rotate it, and this time it is mobilized. And now visco is again injected. Now is the time to introduce the tip of the phaco handpiece. My plan in this case is to do direct chop. That is to hold the nuclear mass with high vacuum and chop the nucleus into pieces. The chopper being used is my own designed chopper. Here it is. Hold the nucleus with high vacuum at the center and chop it like this, and lateral separation is done, and it should not be very much. There should not be any jonular stress when you are separating the nuclear mass laterally. The nucleus is being chopped at another place and it is being emulsified and removed. This is a small bit of the first heminucleus, and this is the other heminucleus. It is being chopped and emulsified. Ultrasonic power used in this case is 50%. Flow rate is 45 ml per minute. Vacuum used is 450 mm of mercury. This is the epinucleus. You must be very cautious when you try to hold the epinucleus. There should not be any power at this time, only little bit of vacuum. Now inject some more viscoelastic substance. This is to keep the antechamber formed if you use Simcoe through the main incision. And the cortex is being cleaned with the help of a direct Simcoe cannula. It's almost done. Now I go through this left side port and remove the sub-incisional cortex. Cortex is removed. There is some fibrous tissue kind of thing sticking to the posterior capsule superiorly. When we remove the cortex, you must be very cautious. Sometimes jonular tear occurs and jonular dialysis can occur. In this case, we have selected a hydrophobic acrylic intraocular lens. This is hydro polish. The posterior capsule is nicely polished with the help of fluid jet coming from the irrigating probe. And now the intraocular lens is being implanted under irrigating fluid. Here it is. The irrigating probe supports the trailing haptic, the optic, and the lens goes into the bag. And now This is a bit of moxifloxacin, and the moxi is being used to hydrate the sideboards. These stab wounds must be nicely hydrated so that there is no leakage of aqueous through these sideboards. The main incision should be such that it doesn't need any hydration. This is the final lavage of the anterior chamber with the Simcoe, and Simcoe is the best for final lavage because you can direct a fluid jet gently towards the corneal endothelium, and whatever sticks to the corneal endothelium can be nicely cleaned. The antechamber is then formed nicely and the case is concluded. Thank you very much. Hope this video will help you in developing your surgical skills. Please develop your surgical skills day by day. Be better and do better service to the mankind.